Imagine trying to rebuild the foundation of a house, but, here is the catch. The plumbing is actively leaking.
Right.
The surrounding walls have been scorched by radiation, and you are absolutely not allowed to turn off the water or, shut down the electricity while you work. Oh, and the space you are working in is barely the size of a grapefruit.
It is the ultimate surgical puzzle.
Exactly. That is the kind of impossible scenario you face when you look at the perineum. Welcome to today's deep dive. We have gathered a massive stack of clinical guidelines, operative case studies, and surgical textbooks for this one.
And our mission today is to take you behind the curtain into the extreme, high-stakes engineering of pelvic and perineal reconstruction.
We are going to explore exactly how plastic surgeons rebuild the body's most complex crossroads from scratch. After massive trauma, congenital conditions, or aggressive cancer resections, you are going to see how we essentially use spare parts engineering to give patients their lives back.
But to really understand the stakes of these clinical reviews, you have to visualize the anatomy. We are talking about a diamond-shaped region at the very bottom of the torso.
Right, the perineum.
Yeah. For you listening, if you want to map this out, the top point of that diamond is your pubic bone, the pubic symphysis. The bottom point is the coccyx, your tailbone. And the two side points are the ischial tuberosities.
Which are the bones you're actually sitting on right now.
Exactly. And surgically, we divide that diamond into two distinct triangles. You have the urogenital triangle in the front and the anal triangle in the back.
But as I was reviewing the operative guidelines, one thing kept jumping off the page. The absolute obsession with blood supply.
Oh, yeah.
Why is the vascular network the single limiting factor here?
Because blood supply dictates survival. In plastic surgery, if tissue doesn't have robust, undeniable blood flow, it dies. It is that simple. This entire diamond is heavily vascularized, primarily by the pudendal arteries. In the front, you have branches coming off the femoral artery in the leg. In the back, the internal pudendal artery comes deep off the pelvic vessels.
So it is this incredibly dense microscopic web.
Right. It feeds the skin, the fat, the organs. When you are trying to rebuild this area, you have to either tap into that existing plumbing or, and this is the hard part, you have to bring your own new plumbing with you.
Which brings us to the obvious question. Why are we rebuilding this area in the first place? What happens to obliterate this intersection?
Well, the case studies break it down into two main categories, congenital and acquired.
Let's start with congenital.
Sure. This means a patient is born with a defect in their developmental blueprint. The literature highlights conditions like Mullerian aplasia. In simple terms, this is when the ducts that are supposed to form the female reproductive tract just fail to develop in the womb.
Where you see bladder extrophy, right?
Yeah, that rare defect where the bladder develops inside out and is actually exposed on the outside of the abdominal wall.
Those require highly complex early interventions. But the massive canyon-like defects, the ones that really require heavy-duty biological engineering, those seem to come mostly from acquired conditions.
Primarily cancer.
Right.
That is exactly what drives the most extreme reconstructions. Primary or recurrent colorectal, urologic, or gynecologic cancers. The ablative surgeons, the ones removing the tumor, have one job, right? Get the cancer out.
And sometimes that requires a total pelvic exoneration.
Exactly. They remove the bladder, the lower colon, the rectum, the reproductive organs entirely.
Right.
They eliminate the cancer, but they leave behind a massive empty void in the pelvis.
The operative reviews also mention infectious processes, specifically Fournier's gangrene, which just sounds absolutely terrifying.
Oh, it is a true surgical emergency.
Yeah.
Fournier's gangrene is a rare, hyperaggressive necrotizing fasciitis, basically a flesh-eating bacterial infection of the perineum and genitalia. It spreads along the fascial planes, the connective tissue under the skin, at an astonishing rate. The tissue death is so rapid that in real life, you have to aggressively debride massive amounts of infected tissue just to save the patient's life.
So whether it is from removing a tumor or cutting out an infection, you are left with this enormous anatomical void. Which brings us back to my earlier analogy. It is like rebuilding Grand Central Station while the trains are still running.
That is a perfect way to look at it.
You have constant fluid traffic from the urinary and GI tracts. You have old surgical scars, and critically, the tissues left behind have usually been completely blasted by radiation therapy.
And that radiation factor, it really cannot be overstated. Radiation obliterates the microvascular networks. It turns the surrounding tissue into a scarred, fibrotic, hypoxic desert.
There's just no blood flow.
None. And if you just leave that massive pelvic cavity empty after removing the organs, well, the body abhors a vacuum. That dead space will immediately fill with fluid. Or worse, loops of the small intestine will fall down into the void and get trapped.
And when fluid just sits in a dead space in the body, it gets infected.
Almost inevitably.
Mm.
You get massive pelvic abscesses, the surgical wounds burst open, or the trapped bowel gets obstructed. To prevent a catastrophic failure, you have to fill that cavity with healthy, well-vascularized tissue.
You need biological spackle.
Exactly.
So how do you actually do that? The surgical guidelines outline something called the reconstructive ladder. Can you walk us through how a surgeon decides what tools to use?
Sure. The reconstructive ladder is essentially a philosophy of starting simple and moving to the complex only when necessary. If you have a small, superficial defect, you might just stitch it closed.
Makes sense.
If it is slightly larger, you might use a skin graft, which is essentially shaving off a thin layer of skin from the thigh and placing it over the wound.
But wait, didn't we just establish that irradiated tissue is a vascular desert?
We did.
So a skin graft is basically biological wallpaper. It relies entirely on the wall behind it to provide nutrients. If you stick wallpaper to a dead irradiated wall, won't it just peel off and die?
That is the exact mechanism of failure. In a heavily irradiated or contaminated field, skin grafts and small local flaps are practically useless. The wound bed just cannot sustain them.
So you have to skip steps.
Right. For these massive pelvic defects, you have to skip the bottom rungs of the ladder entirely. You have to bring in an immediate massive block of tissue that comes with its own completely independent blood supply.
Enter the absolute workhorse of perineal reconstruction. The reviews call it the VIP of flaps, the vertical rectus abdominis myocutaneous flap, or the VRAM. Tell us about this beast of a flap.
The VRAM is ingenious. You are essentially taking the rectus abdominis muscle, what you would know as one of the six-pack muscles on the abdomen, along with the skin and fat overlying it.
Okay.
But the crucial part is that you leave it attached to its primary blood source, the inferior epigastric artery and vein, down near the groin. You cut the muscle free at the top near the ribs, and you swing this massive living block of tissue down into the pelvis like a trapdoor.
Okay, I have to pause here because the mechanics of this are wild. You are taking a massive chunk of core muscle, rotating it, and tunneling it deep down into the pelvis. Isn't there a huge risk of twisting that blood supply?
Oh, absolutely.
It sounds like taking a garden hose and bending it severely right at the spigot. If you kink the hose, the water stops.
And that is the nightmare scenario for any microsurgeon. Pedicle twisting or kinking is the single biggest mechanical risk of the VRAM. The geometry of the transposition has to be perfect.
Or else what?
If that pedicle kinks even slightly, the blood pools, the vessels thrombose, and that entire massive block of tissue dies inside the pelvis.
Wow. And beyond the geometry, the texts mention that the patient's own body type plays a huge role in whether this works.
That is a common pitfall. The skin panel of the VRAM relies on tiny, perforating blood vessels traveling from the muscle up through the fat to the skin.
Right.
In highly obese patients, that layer of subcutaneous fat is too thick. The tiny vessels can't reach the skin effectively, meaning the surface of the flap is highly unreliable and prone to dying off.
But despite those challenges, the data shows the VRAM is still the gold standard for filling huge pelvic voids, right? Just because of its sheer volume.
It is. But a surgeon always needs a plan B.
What if the patient has had prior abdominal surgery, or they are too obese and the VRAM isn't an option?
Then you look toward the legs. The gracilis flap is a fantastic backup. The gracilis is a slender muscle on the inner thigh. The massive advantage here is that it sits completely outside the radiation field.
So you don't even have to open the abdomen to get to it.
Exactly.
The trade-off, though, seems to be the leash. The blood vessels feeding it, the pedicle, are notoriously short, right?
They are very short. The main blood supply comes from a branch off the femoral vessels. To get enough reach to stretch that muscle all the way up into the pelvis, surgeons have to dissect incredibly high up into the groin.
Just to get slack.
Yeah, severing minor blood vessels just to gain an extra centimeter or two of slack, and even then it doesn't provide nearly the bulk of the VRAM.
Now, there is another backup option in the literature that frankly sounds like science fiction. The pedicled greater omental flap.
Oh, it is one of the most brilliant physiological workarounds in the body.
Explain it for us.
The greater omentum is a large apron of fat and immune tissue that hangs down from the stomach, draped over the intestines.
So you are literally borrowing from the digestive system to fix the pelvis. How does that even work?
Well, the omentum has a spectacular blood supply based on the gastroepiploic vessels along the stomach. Surgeons detach it from the colon, leaving it attached only to the stomach's blood vessels, and pull it all the way down into the pelvis.
I read one analogy that compared the omentum to a biological sponge and a sprinkler system combined.
That is highly accurate. Because it is so rich in blood vessels and lymphatic channels, when you pack it into an irradiated, scarred pelvis, it acts like a sprinkler system bringing fresh oxygen.
While simultaneously acting as a sponge.
Right, to soak up inflammatory fluid and improve lymphatic drainage. It drastically reduces the risk of pelvic hernias.
It is incredible. You are moving pieces of the puzzle around just to keep the whole machine running. Now, having established this heavy-duty toolkit, the case studies pivot to how these flaps are applied to specific anatomy. Let's look at female anatomical restoration first.
Okay, yeah.
Because the engineering goals here shift from just, filling a void to creating a functional receptive space.
The functional goals dictate everything. Anatomically, the vagina sits between the bladder and the rectum. It is essentially a muscle-walled cylinder, roughly 6 to 7.5 centimeters along the anterior wall and about 9 centimeters posteriorly.
Let's go back to the congenital issues, specifically Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH. The data notes this affects roughly 1 in 4,500 female births.
Right. In MRKH, a young woman will have completely normal genetics, normal ovaries, and normal external genitalia.
Ah.
But because of a developmental glitch, the vaginal canal and uterus are simply absent. There's just a small dimple where the opening should be.
The approaches to fixing this are fascinating because the first line of defense isn't actually surgical at all. It is the Frank method.
Yeah, the Frank method relies on the body's natural elasticity. It uses a series of progressive dilators to physically stretch that anatomical dimple over months to create a canal.
The problem is it requires intense daily commitment.
It does. It can be painful, and compliance among teenagers is understandably quite low.
Which brings us to the surgical gold standard for this condition, the Abby McIndoe operation.
Right. In this procedure, the surgeon physically dissects a space between the bladder and the rectum. But remember, the body wants to close empty spaces.
It abhors a vacuum.
Exactly.
Yeah.
So they line that new cavity with a skin graft, usually taken from the buttocks or thigh, and wrap it around a silicone stent.
Like a mold.
Yeah, the stent acts as a mold, holding the skin graft against the walls of the cavity until it heals and takes root.
But that is for a clean, non-irradiated congenital defect. When we look at acquired defects from cancer resections, the game changes entirely. This is where the literature introduces the Cordeiro classification system.
It's basically a surgical roadmap.
Right. It dictates which flap you use based on exactly which wall of the vagina is missing.
And the Cordeiro system is brilliant in its logic. For example, type 1A defects involve the anterior or lateral walls, usually after urologic cancers.
You don't need massive bulk here, do you?
No, you need thin, pliable tissue. The ideal choice is the Singapore flap, which is pulled from the inner thigh and the perineum.
And the texts emphasize that the Singapore flap is a sensate flap. Explain why that distinction is so critical.
A sensate flap means you aren't just moving skin and fat. You are intentionally preserving the pudendal nerve branches that supply that tissue.
So the nerves come with it.
Exactly. When you move the flap into the pelvis, the nerves come with it. It means the patient retains physical sensation in the reconstructed area, which is vital for quality of life and sexual function.
Compare that to a type 1B defect, which involves the posterior wall, usually after colorectal cancer.
For a posterior defect, you are sitting right up against the space where the rectum was. You need a structural barrier to prevent hernias.
So a thin sensate flap won't work.
No, it won't. This is where you bring in the bulky, muscle-heavy VRAM from the abdomen to reinforce that back wall.
And if the entire cylinder is gone, a type 2 circumferential defect, the guidelines show surgeons either rolling a massive VRAM flap into a tube or taking bilateral gracilis muscles from both inner thighs and sewing them together to recreate the canal.
But this really highlights the most important decision a surgeon makes. You aren't just matching a flap to a hole. You have to match the engineering to the patient's actual life.
Explain that a bit more.
Well, for a younger patient, a sensate flap that preserves sexual function is a high priority. But for an elderly patient who just underwent a devastating 12-hour cancer resection,
Minimizing time under anesthesia is the priority.
exactly. In that case, a rapid muscle-only VRAM, just to safely obliterate the dead space, is the best medical decision.
It is about treating the human, not just the anatomy. Now, when we pivot to male anatomical restoration, the physiological requirements flip completely.
Oh, completely. In female reconstruction, the primary engineering challenge is creating a functional internal cavity. In male reconstruction, you are tasked with rebuilding complex, pendulous external structures.
It is a totally different ballgame.
You have to engineer a watertight conduit for urine, reconstruct erectile capability, ensure sufficient anatomical length, and restore tactile sensation.
Let's start with the scrotum, particularly in the aftermath of a massive infection like Fournier's gangrene. When the skin is utterly destroyed by necrotizing fasciitis, how do you rebuild a structure that needs to expand and contract?
If the defect is small, you might just stretch the remaining skin. But for massive tissue loss, you rely on meshed split-thickness skin grafts.
Well, mesh mage, meaning the graft literally has tiny slits cut into it, like a chain link fence.
Exactly. The meshing allows the graft to stretch, but more importantly, it allows fluid and exudate to drain out through the holes.
Because if fluid builds up,
If fluid builds up under a solid graft, the graft lifts off the blood supply and dies. But the truly ingenious part of scrotal reconstruction involves the tests themselves.
yes. This was my favorite detail in the entire stack of sources. The testes are utilized as natural tissue expanders.
It is amazing. As long as the thin protective layer over the testes, the tunica vaginalis, is intact, surgeons will apply the meshed skin graft directly over it.
And because they naturally hang downward, gravity does the work.
Over several months, the sheer weight of the testes acts as a gravity-assisted anchor, gently stretching and pulling that grafted skin down until it forms a natural, dependent anatomical pouch.
You are harnessing gravity and time instead of using synthetic silicone expanders, though the reviews do warn about temperature control. If the defect is so horrific that the testes have to be temporarily buried under the skin of the thigh just to keep them alive.
The higher core body temperature can shut down sperm production.
Right, which is why thigh pouches are only a temporary lifeboat until true scrotal reconstruction can happen.
Exactly.
Let's move to the most microsurgically demanding aspect, penile reconstruction. Whether it is from trauma or gender affirmation, building a functional structure from scratch relies heavily on the radial forearm free flap.
The forearm is chosen because the skin is thin, pliable, and relatively hairless. But the engineering is complex. You have to create a tube within a tube.
How does that work?
The surgeon rolls a section of the forearm skin inward to create the new urethra, the inner pipe. Then they roll the remaining skin outward to create the external shaft.
And they bring the nerves with it.
They harvest the lateral antebrachial cutaneous nerve from the arm. Under a microscope, they meticulously stitch that forearm nerve directly to the remnant of the dorsal nerve of the penis.
So the brain can remap it.
Right, that neural connection is what allows the brain to eventually map sensation back to the reconstructed tissue.
But the stakes get even higher when you aren't building from scratch, but rather reattaching. Penile replantation after a traumatic amputation is a race against a brutal ticking clock.
Replantation is the ultimate test of a microsurgeon. The guidelines are absolute here. You have a strict window of about 6 hours if the tissue has been at room temperature.
Warm ischemia.
Yeah. You can stretch that to 16 hours if the amputated tissue was immediately placed on crushed ice to slow down cellular death.
Walk us through exactly what happens when that patient hits the operating room. The sources outline a highly regimented 5-step process to put the machinery back together.
Step 1 is restoring the conduit. The surgeon places a catheter and does a 2-layer closure of the urethra. You have to make sure the internal plumbing is watertight first.
Makes total sense.
Step 2 is microscopic exploration. The surgeon carefully dissects the crushed tissue to find the tiny, retracted blood vessels and nerves.
Step 3 is structural, right?
Yes. They stitch together the tunica albuginea, the tough fibrous envelope inside the shaft. You have to restore that structural integrity so the organ can withstand physical pressure later on.
Then step 4, the microscope comes down and the vascular work begins.
And this is where the clock is really ticking. The surgeon has to connect the dorsal arteries and veins. To give you an idea of the scale, they're using 11O nylon sutures.
Which is incredibly thin.
That thread is significantly thinner than a human hair. They are sewing together blood vessels that are just 1 or 2 millimeters wide to restore blood flow before the tissue dies.
And finally, step 5. The most delicate work is saved for last. The nerve repair.
They perform an epidural repair of the dorsal nerve. They are meticulously stitching only the outermost sheath of the nerve together.
Because if you stitch through the center,
You crush the nerve fibers and ruin the pathway. And throughout all of this healing, they divert the urine through a tube in the abdomen, so the fresh urethral surgical site isn't compromised by fluid pressure.
when you lay it all out like that, the 5 steps, the microscopic sutures, the race against the clock, it really highlights the staggering adaptability of the human body. We are taking core muscles from the abdomen, tunneling them through the pelvis, and making sure they don't kink like a garden hose.
We are taking an apron of fat from the stomach to act as a biological sprinkler system.
We are taking nerves from the forearm and plumbing them into the pelvis to restore feeling.
And that really highlights the trajectory of where this entire field is heading. We talked about connecting a forearm nerve to a pelvic nerve to restore sensation.
Right.
As our microsurgical tools improve and as our understanding of nerve regeneration deepens, it raises a truly profound question.
What's that?
How close are we to a future where nerve grafting is so utterly seamless that these transplanted spare parts don't just mimic the original anatomy, but integrate and function so perfectly that the brain cannot tell the difference?
It changes the entire definition of what it means to be reconstructed.
Absolutely.
Something for you to think about the next time you marvel at the engineering of the human body.